This is an in-service based on the role of occupational therapy in spinal bracing. It is being facilitated by the Occupational Therapy Department in the Midlands Regional Hospital in Tullamore. This presentation compiles of 4 sections to include spinal anatomy, bracing as a treatment modality, the role of occupational therapy in spinal bracing, and the OT process. We will begin by briefly having a look at the anatomy of the spine. As we can see in the diagram, the spine contains 4 segments: cervical, thoracic, lumbar, and sacral. The cervical spine contains 7 vertebrae and supports the weight of the head. The thoracic spine contains 12 vertebrae and holds the rib cage. The lumbar spine contains 5 vertebrae, and the purpose of this part of the spine is to bear the weight of the body. In the sacrum, there are 5 fused vertebrae. And finally, the coccyx region, which contains 4 fused vertebrae. This is more commonly known as the tailbone, and it provides attachment for ligaments and muscles. The cervical spine consists of the C1 to C7 vertebrae. It is the most mobile spinal segment. OTs do not apply spinal braces for injuries or fractures of the cervical spine. These are fit by the orthopedic team. The thoracic spine consists of the T1 to T12 vertebrae. It is the least mobile zone of the spine. OTs only fit the braces for some injuries or fractures below the level of T4. Anything higher than this level is fit by the orthopedic team. Then the lumbar spine consists of the L1 to L5 vertebrae. Its greatest movements are flexion and extension. Now we are going to move on to looking at spinal bracing as a treatment modality. When we talk about spinal bracing, we firstly want to look at the purpose of it. Spinal braces are fit to immobilize or restrict movement of the spine in order to do 2 things. The first is to optimize physical positioning in healing. For example, for acute vertebrae fractures, they help to minimize instability or the likelihood of the fracture impinging on the spinal cord. Once fitted appropriately, the brace can also help to prevent spinal deformities such as subsequent kyphosis due to injury. The second reason is to provide pain relief. A correctly fitted brace offloads weight and pressure exerted through the spine and therefore can reduce pain. The diagnosis which require spinal bracing include vertebrae fractures as a result of a trauma such as a fall or road traffic accident, and also a vertebrae fracture as a result of pathology, which includes spinal tumours or cancers and osteoporosis. Classification of spinal fractures are more generally associated with being stable or unstable. The decision as to whether a fracture is to be treated as stable versus unstable comes from the orthopedic team. Often they may seek the opinion of orthopedics from the Mater Hospital and conduct thorough investigations, including CTs and MRIs, before they can make an informed decision. The type of fracture and degree of stability will determine the treatment approach, whether the fracture is for conservative management or surgical intervention. If the fracture has been classified and documented as stable and is below the level of T4, then often the person is referred to OT for fitting of the spinal brace. The wearing regime of the brace is decided based on the stability of the fracture. So this means when orthopedics refer to OT for fitting of a spinal brace, they are happy for the brace to be worn during the day, and it can be removed overnight as well as donned and doffed in standing. If the fracture is classified as unstable, it is the orthopedic team who look after treatment. The person may require surgical intervention or may be fit with the spinal brace for wearing 24/7. In this case, it is the orthopedic team who choose and fit the most appropriate spinal brace. In this diagram, you can see the spinal care pathway for referrals for spinal patients to the Midlands Regional Hospital in Tullamore. It is divided into 2 categories: internal referrals, this is referrals that come from within the hospital, and external referrals, which are referrals from external hospitals. In the internal referrals category, the referral may be received for a patient who is either an inpatient who has been admitted to the hospital or an outpatient who is attending trauma clinic or in the emergency department. If the fracture is deemed as unstable, the patient is seen and managed by the orthopedic team. If the fracture is deemed as stable by orthopedics, then they will refer to the OT department for fitting of the brace. In the external referral category, the referrals are sent from the external hospital directly to the orthopedic department. The patient is then seen by orthopedics for the diagnosis to be confirmed. The patient will then be seen by the team either virtually or in the next trauma clinic. If the fracture is deemed as unstable, again the patient is seen by orthopedics for fitting of the brace before being transferred back to the external facility. If the fracture is deemed as stable, orthopedics will then refer directly to the OT department, who will see the patient for fitting of the brace before the patient is transferred back to the external hospital. Now we will move on to the role of OT in spinal bracing. As OTs, our clinical skills in both splinting and orthotics and facilitating function offers us a unique role in treating patients with spinal fractures. Though OT is not the only profession that can offer a service of spinal bracing combined with spinal precaution education, we are well equipped to deliver a comprehensive quality of service in terms of practically translating medical orthopedic intervention into activities of daily living. As discussed earlier, OT in Tullamore only offers a bracing service to confirmed and documented stable spinal vertebrae fractures. However, we also offer spinal precaution education regardless of the type of brace the person is fitted with. The education provided to patients in respect to applying spinal precautions to activities of daily living following hospital discharge helps minimize pain, optimize independence, and promote optimum healing. This slide explains the guidelines followed by OT when we receive a referral prior to fitting of the spinal brace. Firstly, we check what level the fracture is. As explained previously, OTs do not brace anything of the level of T4 or above. Then we check if the fracture has been confirmed as stable and documented as stable by the orthopedic team. We ensure all investigations have been completed, such as an MRI or CT. All investigations and subsequent reports must be completed prior to referring to OT. We review the patient's medical history to see if there is anything significant that may impact fitting of the brace, such as a respiratory condition, a cognitive impairment, a stoma or hernia. And finally, we check if the patient has been given an outpatient follow-up appointment by orthopedics. When fitting the brace, it is essential to know the brace wearing regime. There are different wearing regimes of the spinal brace depending on the nature of the fracture or injury. In category A, the brace must be worn at all times, i.e. 24 hours for the duration of the next 6 to 12 weeks or as long as advised by the consultant. This is generally the approach used for unstable or query unstable fractures. For a 24-hour wearing regime, the brace is always fitted by the orthopedic team and the person is log rolled into the brace. In category B, the brace is only to be worn during the day and can be removed at night or for hygiene purposes for the next 6 to 12 weeks or as long as advised by the consultant. This is generally the approach for a confirmed stable fracture. In category C, the brace is worn for comfort and pain relief measures only, i.e. for chronic conditions. In this circumstance, the brace is only worn during activities that tend to cause and aggravate pain, usually unavoidable tasks that require bending and twisting of the spine. This is the approach for old injuries where the purpose of bracing is for pain management only. There are a number of different types of spinal braces in Tullamore Hospital, which can be seen here in the picture on this slide. The OT will decide on what spinal brace is most appropriate for fitting based on a number of different factors. We will emphasise the name and the wearing regime on their orthotic instruction sheet and the transfer letter if appropriate. The key considerations when deciding on a spinal brace are the type of fracture, the level of fracture, the person's shape, a person's cognitive ability, a person's activity level, their skin integrity, comorbidities, and the reason for the brace. Finally, in this section, we will look at the OT process for spinal bracing. In terms of the OT process, to give an overview, we start by completing the assessment and fitting of the spinal brace. We then complete education on brace care and spinal precautions. Next, we complete education on activities of daily living. This includes how to get in and out of the bed using the log roll technique, and also looking at dressing and if the patient requires any lower body dressing aids. Once everything is satisfactory, the patient is then discharged from OT with the required information sheets. Typically, the patient is discharged from OT at this point and should be followed up by the orthopedic team. If there are issues with the brace, the patient can contact the OT department directly. We aim to have our contact information on the information sheets and also the name of the orthopedic consultant so patients can contact the relevant secretary with any queries. In the case a patient has been transferred from an external hospital, then the OT in Tullamore will complete the assessment and fitting of the spinal brace and also complete the spinal precaution education. The patient would then be referred back to the OT in the external hospital for the review of spinal precaution education, an initial interview and functional assessment and the discharge planning. When the patient is transferred back from Tullamore to the external hospital, they will have been provided with the transfer letter, an orthotic instruction sheet and a spinal precaution and brace care instruction booklet. These will be provided to either the patient or the person in attendance with the patient as appropriate. This is an example of the orthotic instruction sheet that all patients fitted with a brace by OT will be provided with. It includes information on the patient's details, the details of the therapist who fit the brace, the name of the brace, the wearing instructions, cleaning and care advice, and skin care advice. This is the front page of the Spinal Precautions and Brace Care booklet, which the patient will be provided. It contains information and pictures in relation to spinal precautions, including bed transfers and dressing techniques. This is the transfer letter, which a patient who is transferring back to an external organisation will receive. No matter what spinal brace that has been provided or what wearing regime has been advised, it is important that all patients adhere to spinal precautions. Spinal precautions are basically the do's and don'ts. These precautions involve what movements to avoid and how to modify your activities of daily living to best accommodate these precautions. It is extremely important to adhere to spinal precautions in order to minimize pain and discomfort and to reduce the risk of further injury. By adhering to the spinal precautions, the person will also be keeping the spine in the best position to allow for healing. The main precautions which will be elaborated on include avoiding bending and twisting. When advising avoiding bending and twisting, we speak to the patient about activities of daily living which may involve bending and twisting and how best to modify this. We look at a person's transfers, including getting in and out of bed. It is important to use the log roll technique for getting in and out of bed, which we will demonstrate to patients. When speaking about dressing tasks, we particularly focus on lower body dressing. We demonstrate how to best don and doff shoes and socks in a seated position. We also assess the patient to see if they require long handle dressing aids in order to assist them with lower body dressing. If the wearing regime of the brace is for wearing during the day and can be removed at night, we also advise patients that the brace can be removed for showering once they adhere to the spinal precautions. This means maintaining a straight position when in the shower, so ensuring no bending for toiletries. In terms of personal care when the brace is to be worn 24/7, we would advise the patient to wear a sleeveless top under the brace or a t-shirt where the armpits can be cut out to allow for easier access to a basin wash. We would also advise the patient to bring a spare change of upper body clothes to their follow-up orthopedic appointment so that the orthopedic team can change their clothing when removing the brace for investigations. We also recommend shampoo caps to patients who want to wash their hair. These can be purchased in most pharmacies. If the wearing regime of the brace is for during the day only and can be removed at night, then we would also advise that it can be removed for showers once the person is adhering to spinal precautions. Now we will look at what to do when the brace isn't fitting correctly, how to identify the problem, and then to fix it. If the brace is rising up, then it might not be on tight enough or it may be positioned too low. It also may be because the chair that the person is sitting on is too low, which is bringing them out of an ideal sitting position. If the person has a kyphosis or curve in their spine, the brace may not be facilitating that, causing the brace to move position. A person should feel almost instant relief or comfort when the brace is fitted correctly. If the brace is rubbing against the person's skin, causing irritation, then this may be caused by the brace being on incorrectly, such as being upside down or back to front. The brace may also be on too tight or too loose. The person may have inappropriate clothing under the brace, which may be wrinkled up, causing sites of friction against the skin. If the brace is not limiting a person's flexion, extension, or rotation, then this may be down to it being on too loose, not in the correct position, so sitting too high or too low, or they have been fitted with a brace which may not be meeting their needs. We would recommend considering these options, and if the query has not resolved, to contact the OT department. In terms of follow-up for the patient, we speak about follow-up with the OT department or follow-up with the orthopedic team. As previously discussed, the patient is not typically followed up by the OT department. However, if the brace was fitted by OT and there are any concerns in relation to the brace or queries regarding a person's functional activities, then they can contact the OT department directly. If the person is in a brace fitted by the orthopedic team for 24/7 wear, then the orthopedic team must be contacted with any issues with the brace. Also, if there are any concerns regarding the injury or a person's pain management, then the orthopedic team should be contacted. As mentioned earlier, we would aim to have the treating consultant's name noted on the orthotic sheet or booklet so the patient can access the relevant secretary directly via the main hospital line.